So guys, genetics is actually quite one of the common topics in the CSA, which was one of the previous exams for GPST3 candidates. So now the SCA is back. We are expected to actually be familiar with genetic problems. And it's one of the cases we should be expecting could come out in the SCA. So there could be a scenario where someone has come to speak with you, a patient has come to speak with you about concerns, considering conditions like cystic fibrosis, hereditary hemochromatosis. I think these are the two common ones that could likely come out in the SCA. But there could also be something like hemophilia. So it could be a patient who wants to talk about hemophilia, when a patient is hemophilic, or their brother has hemophilia, and they want to talk about the chances that maybe their child might have hemophilia or something, or their partner has hemophilia, and they're concerned about the risk of their children, inheriting hemophilia, and they want to talk about those things with you. So it's good to be able to know. Usually, what we've been told so far, usually if there's a genetic condition, usually in the case summary, which you have 3 minutes to go through, usually you'll be told the mode of inheritance of that particular condition. So if it's a case of cystic fibrosis, usually you'll be told that it's autosomal recessive. Hemophilia, of course, is X-linked recessive. So let's just do I've just put these together. So a rundown of what these modes of inheritance entail. So for autosomal recessive, we know that, of course, I've just chosen A to represent the gene, and the X is the abnormality. So I've put this X there as the abnormality. So I put that X there as the abnormality. So the abnormal gene or the faulty gene is this one. Because it's recessive, obviously, I put it behind. And let's say this is the person that is coming. Let's say this is the person that is coming to talk to you, these patients. And they're concerned that their child could have that. Maybe they're carriers of cystic fibrosis, for instance, which is an autosomal recessive condition. They're concerned about their child inheriting that cystic fibrosis gene. Maybe they're often concerned that maybe their child could have cystic fibrosis disease as itself, and they want to find out how likely are they to transmit that abnormal gene to their children. The most important thing to understand is that if you're going to be explaining to this patient that since you're a carrier of cystic fibrosis, it means you've inherited only one faulty gene from one of your parents, which means you have one faulty gene and one normal gene, and that's why you're not having cystic fibrosis, condition, but you carry the faulty gene. And now there's a likelihood for each of your pregnancies, there's a likelihood that you may or may not pass on that faulty gene to your child in each pregnancy. And the likelihood of you passing that gene over to your child is completely by random selection. It's something that happens completely randomly. There is no way you're able to predict which gene, whether you're going to pass the normal gene or the faulty gene to a child, and that applies to every pregnancy. And now, whether your child is going to have cystic fibrosis or not also depends on the genes that your partner has. If your partner has 2 normal copies of their genes, then obviously they're not contributing any faulty gene. If your partner is also a carrier, so there's a chance that your partner as well could transmit that cystic fibrosis gene to the child. And if it happens that you transmit the faulty gene and your partner transmits the faulty gene, if it happens by chance that happens in that particular pregnancy, then what it means is that child is going to inherit the 2 faulty genes, and then that child will have a cystic fibrosis. Or if it's only the partner, so the thing is that we don't really, more in the UK, there is a screening for cystic fibrosis. When a neonatal blood spot test is done, the panel of blood tests done, in newborns, cystic fibrosis is tested. So there's a high likelihood that if your partner is not aware that they're carriers of cystic fibrosis, there's a high likelihood that they would not have that gene. It's like high likelihood they don't have the cystic fibrosis gene. But I think usually the testing may not identify, the neonatal testing may not identify carriers. It probably will identify only babies that have cystic fibrosis. I'm not very sure about that. I think I also need to confirm that detail. So obviously, if the person is a carrier, and then you explain that if your partner doesn't have this abnormal gene, then there's a 1 in 4, or there's a 2 in 4 rather. There's a 2 in 4 chance, which is a 1 in 2 chance, or 50% chance, 50% chance that your child could have to be a cystic fibrosis carrier. There's a 50% chance that your child will not be a carrier, will have 2 normal copies of their gene. And so, but then something that is so important to stress is that the inheritance pattern, what the genes your child eventually inherits, also depends on the genetic makeup or the genes that your partner has. And that's something that is so important. But then the patients might be a cystic fibrosis carrier, and the patient I want you to explain how they even got this cystic fibrosis gene in the first place. And because they are carriers, what it means is that they inherited a faulty gene from one parent and inherited a normal gene from the other parent. What it means is that they're not going to develop cystic fibrosis because they only carry the faulty gene, but they're not going to manifest the condition. Now, another scenario could be, you want to also be able to explain this to the patient. If, as we said, if their partner is also a cystic fibrosis carrier, let's assume the patient that's coming to you and their partner have the cystic fibrosis genes, so they're carrying it. If you do this Mendelian cross-match, you see that this one will have, so both of them are carriers. There's a 1 in 4 chance that if this one and this one join and have this, there's a 1 in 4 chance, which is a 25% chance, that the child will have cystic fibrosis. But then the child will be homozygous for the cystic fibrosis gene. Here, there's a 1 in 4 chance, which is 25%, that the child will have the normal genes. We inherit 2 normal copies of the genes. There's a 2 in 4, which is a 50% chance that the child will be a carrier of cystic fibrosis, from what we can see here. So it still boils down to the fact that how the genes the child eventually inherits depends to a large extent on the genetic makeup of their partner. Again, if the patient is a cystic fibrosis carrier, but the partner has cystic fibrosis, which I think obviously would not be a very good decision. If you know you have cystic fibrosis, then why go ahead and marry someone that already has cystic fibrosis? It's not a really wise decision, isn't it? But let's assume they're so much in love and they go ahead to get married, decide to go ahead and get married, even after knowing that you're a carrier and your partner has the condition. When you do the Mendelian cross-match, this is a carrier, cystic fibrosis. What it means is that there's a 2 in 4, which is 50% chance that the child in every pregnancy will be a carrier. And in every pregnancy, there's a 50% chance again that child is going to have a cystic fibrosis disease or condition. Okay, because here they'll be homozygous. There's a 50% chance of having the homozygous state. Here's heterozygous. So it still boils down to the genetic makeup of the partner. Now let's look at autosomal dominant conditions. For the CSA, I'm presuming that they will more likely come up with autosomal recessive conditions. I don't know why, cystic fibrosis and hemochromatosis, but of course they can always bring things like conditions like, Marfan syndrome, Ehlers-Danlos syndrome, autosomal dominant polycystic kidney disease, conditions that have autosomal dominant inheritance patterns. Usually, they will tell you that this condition is autosomal dominant, so you usually be aware. So let's look at autosomal dominant. Obviously, because it's an autosomal dominant, so we'll put it in front there. So let's assume the partner doesn't have the gene. Obviously, if the partner has the abnormal gene, because it's autosomal dominant, the partner will also have the condition. But let's say the partner doesn't have that abnormal gene, only the patient that is speaking with you. So if you look at that, by the time you do the Mendelian cross-match, you can see that anybody that inherits that abnormal gene will have the condition because it's autosomal dominant. So there's a 2 in 4, which is 50% chance of So this is actually wrong. It shouldn't be carrier, it should actually be diseased, isn't it? Because autosomal dominant. But there's a 50% chance that whoever that's your child from every pregnancy will have the condition, not carrier, will have the condition. And there's a 50%, which is 2 in 4 chance that the person will be normal. The person will not have the abnormal gene or will not have the condition. Now, still on autosomal dominance inheritance. Let's assume the patient has condition because it's autosomal dominant. Let's assume their partner also has the condition, which is autosomal dominant. So it would be so weird for two people with Marfan syndrome, for instance, to get married if both of them already know that they both have Marfan syndrome. It probably wouldn't be a wise idea, isn't it? Because you're going to pass that gene. You're very likely going to pass that gene onto your children. And let's assume that each person has only one copy of the abnormal gene, because there's still a chance that they could have 2 copies of the abnormal gene, depending on their parents, isn't it? So let's assume both of them have only 1 copies of the abnormal gene. And without doing the Mendelian cross-match, this person has a condition, this person has a condition, this person has a condition. So there's a 3 in 4, which is 75% chance that any child from every pregnancy will have the condition. This one doesn't have it, so there's a 1 in 4 chance, which is 25%, that the child from every pregnancy would be normal, will not have that condition. Will not have that condition. Now, still on autosomal dominant, why am I saying some other things? There's something called consanguinity. And consanguinity simply means people that marry from within the same family, that within the same nuclear family or within the same or within an extended family. So marrying your sibling or marrying a cousin, you know what I mean? So when you're marrying people that are so closely related to you, there's a likelihood that both of you share similar genetic makeup or share similar abnormal genes. And there's a possibility of those abnormal genes coming together to form, to give rise to homozygous states and things like that. So still on autosomal dominant. So let's assume the person speaking with you is autosomal dominant, obviously has the condition, but let's assume that the 2 copies of their genes are faulty and their partner has a condition, but only 1 copy is faulty. In that case, this child is going to have, this child you have, this child you have. So there's a 4 in 4, which is 100% chance that every child they have would have that condition. A common cause of these kind of things, consanguinity. A brother marrying a sister, for instance, or a brother marrying a cousin, there's a likelihood that both of them might have those abnormal genes, and then they'll be passing those genes on to their children. So consanguinity will be a common cause of some of these things. So societies where consanguinity happens or consanguinity is accepted, could lead to, large pools of genetic conditions. And let's look at sex-linked recessive. So sex-linked recessive inheritance, because it's sex-linked to X-linked, right? It's usually on the X chromosome. It now depends, the mode of inheritance now depends on who carries that abnormal gene, the mom or the dad. So I've denoted the abnormal gene there as D. So if it's the dad, XY, that's carrying that abnormal gene, and the mom doesn't have that abnormal gene, by the time we do the Mendelian cross-match, this daughter is a carrier, this daughter is a carrier, the sons will not have it. So for each pregnancy, there is a 100% chance that the females, the daughters, will be carriers. And there's a 100% chance that the sons will not have the abnormal gene. You can see that. But that's for the dad. And let's say the dad has the condition. The mom doesn't have it, but she carries it. She doesn't have the condition, but she's a carrier. By the time we do the Mendelian cross-match, this daughter will be a carrier, this daughter will have it, this son will be normal, this son will have it. Because once any son carries it, because it's on the X chromosome, they will manifest it. So for the daughters, there's a 1 in 2, which is 50% chance of any daughter being a carrier. This daughter has it, this one doesn't have it. Some carries it, but also there's a 1 in 2, which 50% chance again that any daughter they have will have the disease. There's a 50% chance that any daughter they have will be a carrier. Coming to the sons, 1 out of 2 sons for every pregnancy chance will be normal. So there's a 50% chance that any son they have will inherit the normal genes. And there's a 1 in 2, 50% chance, 1 in 2, 50% chance that any son they have will inherit that disease condition. still on X-linked or sex-linked recessive. Let's assume the father doesn't have the abnormal gene, but let's assume the mother is homozygous. So the mother has the condition, for instance, hemophilia, right? Hemophilia is common in men because once any man has the X abnormal gene on the X, he manifests it. But if a woman has only one, she's a carrier. So for a woman to manifest it, she must have the abnormal gene on both her X chromosomes. She must be homozygous. Let's assume a woman is homozygous and she has that condition, hemophilia A or hemophilia B, for instance. Or her husband doesn't have that, or her male partner doesn't have that. And you do the male Mendelian cross match. This female will be a carrier. This female will be a carrier. This male will have the disease. This male has the disease. What it means is that there is a 2/2, so 100% chance that any female child they have will be a carrier, and 2/2, there's a 100% chance that any male child they have the disease condition. Now let's make it even worse. So still consanguinity is something that can lead to some of these kind of things. Especially this one I'm going to talk about now. A man, so let's assume a man has it, a woman has it. It's more likely going to be consanguinity, isn't it? Or if by chance you have hemophilia as a man, and then you meet a lady that also has hemophilia, and both of you decide to get married, going to be quite uncommon, isn't it? But let's assume it happens. But the man has hemophilia, the woman has hemophilia. The woman has hemophilia because she has 2 copies, and it's a recessive condition. So for a woman to have it, she must have 2. The man only has 1 X, so the one moment he has it is going to manifest. Now, what's going to happen in this situation? This child will have it. This female will have it. This girl will have it. This boy child will have it, and this boy child will have it. So for every pregnancy, there's a 100% chance that any child they have will have hemophilia, number 1. Number 2, there's a 2/2, the 100% chance that any girl child or female child they have, any daughter will have the condition. Number 3, there's a 100% chance that any male child they have will have the condition. So the chance, another thing is we have to explain is that the chance of the child having a condition in an X-linked recessive depends on whether the child is going to be male, whether the child is going to be. You may not be able to explain all the full details to the patient in the SCA because that's not really what they want. They're not there to see you show off your knowledge. Obviously, having the knowledge is important, but your ability to allay the patient's anxiety and your ability to explain certain factors, so you to mention those factors that will influence the pattern of inheritance. Things like be able to highlight the fact that the genetic makeup, the kind of genes your partner carries also determines the genes your child inherits. So when it is an X-linked condition, because it's carried on the sex chromosome, it also depends on whether the child is going to be a male or a female child. That also determines whether the child will have the disease or whether the child will be a carrier, in addition to what the genetic makeup of your partner. So all of those things play important roles in determining how this faulty gene will be transmitted to your child or to your offspring. So it's more like explaining the factors that will influence the transmission of that faulty gene than actually mentioning the percentages, if you know what I mean, and making the patient understand that, okay, it's not just about me now, it also depends on the genetic makeup of my partner, which is also very important, and so that's essentially how you need to go about explaining some of these genetic conditions to explain some of these genetic conditions to patients in the SCA exam or in your PLAB exam or any other medical exam where you have to discuss genetic inheritance of different conditions.